Good afternoon, everybody. Welcome. To those of you in the room, welcome to the McMaster Health Forum, and thank you for those of you who are joining us online. My name is James. I am the Senior Lead of Programs for the McMaster Health Forum, and I also help run the Queen Elizabeth Scholarship Program for the Forum. I'm going to give you a quick little summary of the Forum and the Scholarship Program, and then I'm going to introduce you to our guest speaker, who's going to tell you about her fun and adventure that she had while in India studying for her master's degree. And then we'll have a chance to ask questions at the end. If you're online, I'm going to ask that you type your questions in the chat box when the time comes. And for those in the room, you'll just have an opportunity to put your hand up. So the McMaster Health Forum, we are the leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, prepare action-oriented leaders, and we act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between Rideau Hall Foundation, Community Foundations of Canada, Universities Canada, and Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. Here at the Forum, because our focus is on strengthening health systems, that is the focus of our Queen Elizabeth Scholarship Program. So all of our scholars contribute to strengthening health systems and become part of our large and growing network of health system leaders. Here is a list of our current Queen Elizabeth scholars. We are accepting applications all the time, so feel free to apply if you are interested. Our presenter today is Nicola, who's currently a student in the Master of Science in Global Health program at McMaster University. She spent her summer in Mussoorie, India, which is a remote hill station in the state of Uttarakhand in the northern part of the country. While there, she conducted research for her thesis on community mental health of women with depression and anxiety. Nicola's qualitative research aims to determine how a model for community mental health competence can be developed. In other words, how communities can facilitate their own treatment and care of mental health problems. Nicola, on to you.
Okay, great. Thanks, James. So, like you said, I'm here today to talk about a study I did on qualitative research of women in northern India struggling with depression and anxiety. So my presentation today is going to be about 30 minutes. I'm going to start out with a little bit of background on Indian women's mental health, as well as some mental health policies in India, and then move into the research that I conducted this summer. So at the end of this, we'll give you all an opportunity to ask me any questions that you would like. To begin with, currently depression is the leading cause of disability worldwide, according to the WHO. And the burden of depression is 50% higher in women than in men. In India, 6.6% of women have a common mental disorder. What that means is depression or anxiety. And so in a country where there are 1 billion people, that means that there are currently as many women struggling with anxiety and depression as the entire population of Canada. Indian women are at increased risk for common mental disorders due to what Vikram Patel refers to as the double burden of gender disadvantage and poverty, which restricts their autonomy and access to social support. There are also cultural and socioeconomic causes for depression in the Indian women population, and that includes the rigid and traditional gender roles that women in the Indian culture have that really restricts their agency and lowers their social status. Lastly, the exposure to domestic violence also creates an environment which makes women more susceptible for depression. So my study was on psychosocial support groups. And what does that mean? What does that term mean? That means essentially groups of women getting together to learn about mental health and talk about their own mental health. And there's been very little research that's been done on psychosocial support groups. However, research has shown that social interventions can impact mental health, and that women with higher levels of social support experience lower levels of depression. Slide. Here we go. So we're going to start out by looking at some of the current health system weaknesses in the Indian mental health system. So right now, there is a lack of human resources, and that means major shortages of doctors. In terms of mental health human resources, we're looking at around 4 psychiatrists per million people, and the majority of them based in urban areas. So if we compare that to a high-income country like Canada, the ratios are around 200 times higher in high-income countries. As well, there's even poorer access in rural areas, and I was working in a predominantly rural area, where up to half of the positions are vacant, and up to 80% of these specialist positions may be vacant. And so due to the poor reach of the public sector in India, India's India's health system has become one of the most heavily dependent on private health care and out-of-pocket expenditure. So you have a system that's mostly private, but is also largely unregulated. This private healthcare system in India accounts for, in 2014, it accounted for 70% of the outpatient care. However, that's a problem because many of the practitioners are underqualified or unqualified. One study looked at how only 11% of the sampled private care providers had a medical degree, and only half of them had completed high school. Lastly, there are very high out-of-pocket costs. In terms of mental health, although women experience a variety of common health problems, one study looked at how depression is the only one that it causes catastrophic health expenditure for women seeking pharmacological treatment. So when I sat down with the director of the NGO I was working with, I asked her, can you tell me a little bit about India's mental health system? And she said to me, what a mental health system? Some of the work that she's done has contributed to literature showing that only around 10% of the Indian population with psychosocial disability, this includes anyone with a mental health disorder, has access to evidence-based mental health services. So why is there no care? This also relates to the lack of human resources that we saw, the lack of psychiatrists, psychologists. Additionally, a very small budget is reserved or allocated to mental health service provision, currently at 1% of the national mental health budget. Lastly, one of the problems we're looking at is a huge underuse of the services. There are 3 major factors that relate to the underuse. The first one being the lack of knowledge and awareness around what mental health is, how one can get help and support, treatment. The second being stigma and discrimination, causing problems of access to care. And the last one is that there's a lack of skills in the healthcare practitioners and an inability to diagnose or treat any sort of mental health disorder at the primary, secondary, and tertiary levels of care. So just to give a little bit of background, health services in India and in other parts of Asia, Southeast Asia, at the primary care level, we have primary sub-centers, and 5 of those report to primary health centers, or PHCs. Then at the secondary care level, patients are referred up to community health centers, or CHCs, as well as district and public hospitals. And that's where the majority of the women that I was studying would be accessing any sort of mental health care. So to give you a quick timeline of Indian mental health policy, I'm just going to highlight a couple points here. Right here in 1982, this was the first national mental health policy, and it had a focus on trying to integrate primary health care, or integrate mental health into primary health care. It also had a focus on community participation, which was great. However, the policy was not systematically implemented. Next, which is not on the chart, was in 1996, the district mental health plan was established, and its aim was to provide mental health services at the PHC level and the CHC level, as well as to detect mental illness early, to reduce stigma, and to decrease the burden off of mental hospitals. Then, in 2002, we can see here, the government re-strategized the DMHP into the National Mental Health Plan. However, what this did was it amended the focus away from common mental disorders and towards severe mental disorders, as well as increased the focus on pharmacological treatment or medication. And lastly, In 2014 here, we see the launch of the first national mental health policy. So the weaknesses, some of the weaknesses in the Indian mental health policy include the incomplete implementation of some of these policies. For example, the district mental health plan was actually only implemented in 123 of the 652 districts across India. Some critiques of it have highlighted that policies and programs have not been looking at community participation or paying attention to local context or psychosocial approaches. Third, as I've mentioned, there has been a shift towards medication and kind of an overemphasis on community psychiatry being only there for prescription and distribution of medication as a solution. And then we have further problems with integrating mental health into primary care, as well as an underspending of funds. I'm using the wrong one here. So with such a large population and a lack of human resources, we need a different way to treat mental health disorders. With research showing that institutional mental health care has often been proven inappropriate or harmful, there's been a global shift towards community mental health. One systematic review showed that across 17 interventions that used community mental health models, they had improvement on mental health outcomes as well as more cost-effective care. So my study was a community mental health study of community mental health, and it used a specific framework called the Community Mental Health Competency. And this was a framework expanded by authors Campbell and Burgess, and they were really looking at communities as their own experts. So what community CMH competency means is it's a way for communities to work together to better their own mental health, to facilitate more effective care, treatment, prevention, and advocacy. And so there's three areas of it. We have the knowledge, the first area of it, including mental health literacy and health-seeking behavior. Then there's safe social spaces, so feeling included and not non-stigmatized. And then the last area of partnerships and collective action. And so I've been really focused on this area in my research, specifically collective action for mental health. So here we are in Mussoorie in Uttarakhand in northern India, where I was this summer for 3 months. And I want to highlight that my research was conducted in a partnership with a local NGO called Emmanuel Hospital Association. And they set up a local program called Project Burans. And what that program did was set up a number of interventions in the community, some working with religious leaders, with policymakers, others offering door-to-door counseling. And one of the things that they offered and set up in communities was these psychosocial support groups. So what that meant is training a community health worker to go into the community. She or he, in my case, women, because I was looking at the female population, was already working door to door with women, and she would gather together women that wanted to be part of this psychosocial support group. And so every week or every other week, they would meet and they would have a different module. They have a different learning module on a different type of mental health disorder, whether it's anxiety or depression, and ways to cope with that, ways for their family members to cope with that. And the groups were set up so they were split. Half of the groups were caregivers of persons with psychosocial disability, such as a wife caring for her husband, and the other half were those, in fact, with anxiety, depression. And this, I was looking specifically at groups that had been set up for at least 6 months, and the majority had been running for at least a year. So I wanted to get a good idea from those who've been doing it well what was working. So the 3 questions I looked at was, what factors are influencing participation in these groups? How do these groups impact on the women themselves? And then lastly, how do they impact on the community? So let's look at the setting. Like I said, it's in the state of Uttarakhand, the capital of which is Dehradun, and my study was done across 3 different sites. So Mussoorie, the last photo you saw, was up in the mountains. Dehradun is down on the plains. It's a very urban area. And the last site was in Sahajpur, which is a more rural area. So in Uttarakhand, you have a population of 10 million people. And for those 10 million people, there are only 7 psychiatrists. There is currently no state mental health policy, and as of 2 months ago, a limited form of the National Mental Health Plan that I told you about has been approved. A recent study has shown that individuals have 0 access to talk therapy in the state, and 3.3% of the population was able to access psychotropic medication, including antidepressants, for example. So if I give you a little bit of background on some of my methods, I did a focused ethnographic study. What that means is it's a type of ethnographic research where you're able to pinpoint a specific research question that you have and dive quickly into the field, collect a large amount of data, and it involves intensive data analysis. As well, I used a community-engaged research method, and that involves trying to coordinate and collaborate as much with the community as possible and build on the community's own resources. So this meant, for example, me working with a local researcher to help build local research capacity on the ground, as well as making sure that community members are involved in the research as much as possible and that research is disseminated back to them. So I conducted 10 focus group discussions. Those were done in Hindi with the local research assistant, Pooja Pillai, and then they were translated to English. And then I conducted most of the key informant interviews, which were done with mental health professionals. So in terms of data analysis and rigor, I was using thematic analysis with in vivo software. I was using mixed coding, so both open and closed. I did this until data saturation was reached. And I can answer any questions on any of those details later. We made sure to do really careful transcription and translation from Hindi to English, and that member checking was involved. And what this means is that once we generated themes from our research, we were going back into the community and saying, hey, do you agree with what we found? Does this make sense to you? Do you disagree? So making sure that they were congruent. And lastly, there was triangulation of results between myself, the research assistant, and Dr. Karin Matthias, the director of Project Brands. Noisy mic. So the results that we found, the one really major factor that influenced psychosocial support group participation was, in fact, women's freedom of movement. And what this means is women's inability to leave the home. We found that women who were not able to participate in support groups were mostly because they weren't allowed to leave the home, and those who struggled to gain permission to leave home in order to participate. When look at this is what I've established. This is what I've established with the researchers I'm working with. When we look, oh, you really can't read that too well. Well, I will read it to you. When we look at all of the factors, both at the individual level, the household level in the middle, and there over on the community level, all of the factors related to women's movement, freedom of movement. That is to say, employment or education. Women who are already able to go to school are already leaving the house themselves, and therefore they had no problem being able to access the groups and participate in them. At the household level, if you look at family support was crucial. Those families that knew about the groups and were supportive of them meant that the women were able to participate in them. Conversely, families that did not give permission for her to leave the house or participate in the groups made that participation impossible. And lastly, we're looking at community mindset around gender roles, religion, as well as the community's mental health awareness. And so in a community where some of the women were telling us, we're not really allowed out of the house unless it's maybe to go to the market, that's a really difficult situation for them to be able to participate in these groups. As well, with the lack of mental health awareness in the community, it's harder to see the benefits of this. So moving on to I'm just going to go back a slide. Those who were able to participate in the group, how did it impact them? We found that these groups were a safe social space for the women. What does that mean? That means that for women who are not able to speak about this normally, they have a place where they can talk about mental health, and they are not stigmatized, and they can reveal any of their problems. Second of all, we found strength in mental health. That means that women were telling us stories about coming into the groups and previously having depression, anxiety, being unable to work, unable to cope in their lives. And through the group and the support of the other women, they're saying, this isn't really a problem for me anymore. Now I'm, helping other people with their own depression. Lastly in this section was an increase of mental health knowledge. And what that means is that through the modules, the women were learning about anxiety and depression, but they were also learning how to cope with it and how their family members could cope with it. So, a wife saying, oh, my husband's irritated and angry, and, trying for her to understand what this means in terms of in relation to his anxiety and how their family can have a more cohesive home life if she knows, you know what, I'm not going to get angry at him, I'm going to do something different. So they found that was really helpful to get knowledge. This is the wrong clicker. So those three combined, here we can see that safe social spaces strengthen mental health and new mental health knowledge combined into one result that we found that the women referred to as speaking freely. What does that mean, speaking freely? The women said, now that we've been in these groups, we can speak. And when we probed further, we found that it related to confidence in the women. Some of the women, usually half the group, had never been to school before. So in a group of women who have never had a chance to speak in front of a group of people, and at home they're not really able to make household decisions, and they're not sharing in household discussions, this was a place for them for the first time to be able to speak out and talk with other members of the group. So in addition to the increase in confidence, they also had a new knowledge that nobody else had in their communities, a really unique knowledge. No one else knew about mental health. So those factors combined created this ability for them to be able to speak freely. Then beyond that, we see these kind of new horizons, these kind of opening of eyes, and the women saying that now that they have been through the groups, they have a new mentality. They're looking at things different. They want to get their kids signed up for school. They want to help their community. So those were some of the things that we found in terms of impact on women. And then in the middle here, although it's difficult to see, it says reimagining roles as community members. And what we found is that because the women they found that the groups helped them struggle with their own depression and anxiety, they now wanted to turn around and help the community. And they had a very strong desire to share their knowledge, to get out there, to make new groups. They were very excited. And although it's hard to see, there was a shift in their behavior. Before they said, before we were the ones who needed help, but now we're the ones who are helping others. So there's a huge shift in their behavior. And then what impact does that have on the community? Well, in terms of mental health, women were telling us many stories about sharing mental health knowledge. So sharing it, they said, we want to share it with everybody. We want to share it with our neighbors, with our friends, community members, family members, everybody that they could. So that's one way for the community's own awareness and knowledge to increase. Secondarily, they were helping increase mental health access. And what that involved was other stories that they told us about referring individuals in their community to a community health worker who then accompanied them for care. As well, women were accompanying people themselves. They were taking a neighbor to the hospital saying, hey, I think my neighbor has depression or anxiety. I think he really needs to be seen. And they were bringing them all the way to the hospital. So those are some of the results we had on impact on community. The last thing I want to point out is in the non-mental health related category, the women found that the groups could be a source of collective action within their community. And that could mean in any capacity in terms of talking to the local panchayat, the local government, making sure that they were getting their rights, they were able to get their kids signed up for school, and that anything that they wanted to do as a group, they found that they could do it better within this kind of a setting. So those were my results. And now, why is this research important? Well, first of all, this is really important because there's very little research coming out of northern India in terms of mental health. Most of the research is coming out of southern India. Additionally, psychosocial support groups in general have really been understudied, and the majority of studies on them focus around regions in Africa, as well as populations living with HIV. And then in comparison to previous research, this research was unique in two ways, in that it focused on, participatory factors for women, but also how these groups can impact the community. Then if we step into some of our findings, such as women's freedom of movement, it was very significant to find that women were able to work together to improve their mental health in such an environment of high gender inequality and high mental health stigma. And so in the future, greater ability for women to be able to speak out and act collectively can empower women to make decisions at the household level as well as the community level, to participate economically, and to advance their health and social interests. I also want to link the research to the social determinants of mental health. So like we discussed in the beginning, some of the social determinants in India specifically being gender inequality and child marriage, isolation, and poverty. In that same way, the women's freedom of movement can be connected to the social causes of depression. Not only does it cause isolation itself if a woman cannot leave the home, but it's impeding her access to care. Therefore, we need to address women's inability to leave the home in order to address their mental health. And further research should make sure that they include a focus on women's freedom of movement. Lastly, as I highlighted before, this research shows how helping the women was in fact able to help the community, and that educating the women about mental health created more mental health awareness and access to care within the greater community. I'm at this stage in my research, and I would love any other input from the audience on other aspects of this discussion and the research's importance within the current literature. In conclusion, this research highlights the importance of understanding models of community mental health services that build on local resources. It can serve as a model for other underserved areas. And lastly, we must look to community-based solutions to provide support and pathways to recovery where little or no mental health treatment is available. Thank you very much for your presentation, for listening. Just some acknowledgement to Queen Elizabeth Scholarship, as well as Manual Hospital Association, my supervisor, Dr. Lisa Schwartz, and thesis committee member, Dr. Elise Nouvet, the Global Health Department, Dr. Karen Matthias, and Pooja Pillai. Thank you. There's some references.
Great. Well, thank you very much, Nicola. So at this point, we will ponder everything that you've told us, and we will think about some questions we might like to ask. So while everybody's thinking, I will ask a question of you, and I'm sure that you're prepared to answer it. So now that you've done all this research in Northern India, you have a good sense of what the community structures are like and what the mental health issues are. How would you then translate that back here to Canada? So what's the learning that you can bring back home for us?
Yeah, that's a great question, James. Where's the clicker? I actually prepared a slide or two about that. So I've been reading a lot in what mental health, when mental health comes into the news, I've been reading about it in CBC and Globe and Mail. And currently, Canada, the second leading cause of death in the young population is suicide. And in India, suicide is actually the leading cause of death in those who are young. But Canada, unlike many other high-income countries, currently has no national suicide prevention strategy. And so when we have these same kind of big problems across the world, we need to look to common solutions. When I look at the work that Project Baranz is doing, I think that this kind of work can be brought back to Canada. For example, one of the programs that they're doing is working with the youth. So Project Baranz is working with young men and women to increase resilience and coping skills. And these kind of skills are what strengthen the mental health of young individuals, and they can be brought back to Canada. And secondarily, I have one other thing I wanted to, oh, this is the wrong clicker. I wanted to highlight one thing. So if you look at the Toronto Central LHIN, it's got 63 psychiatrists per 100,000 people, or 6,300 per 10 million. And in Uttarakhand, they only have 7 psychiatrists per 10 million. However, research coming out recently is still showing that demand for care is high and that we don't have enough psychiatrists. So the answer is not that we need to train more psychiatrists. We need to do more with the resources that we do have. And so I was looking at a quote here from Dr. Paul Kurdiak. He did his work, his research at CAMH and through ISIS, and he said, we have the opportunity here to rethink the entire system. And I think that's kind of the step forward. I was reading some articles about the UK, where they're integrating psychologists and social workers into the publicly funded care. And things like that, as well as community-based approaches, are what we need to be doing to rethink our entire system and bring that back to Canada.
Thank you, Nicola. It's a good thing I asked that question, since you had those slides already prepared. So if you are online, please type your questions in the chat box. And for anybody in the room, if you have any questions, please let me know. Yes, go ahead. Okay, so the question in the room, for those of you who are online, is about the male side of the equation and whether or not going forward we need to have a similar study on men to study either their mental health or about the empowerment of women.
Yeah, push the issue forward.
Pushing the issue forward, okay, there you go.
Yeah, that's a great question. So when we did our research, we looked at that specifically and we said, what would help, women be able to access mental health services? And the number one answer was support from the husband. So making sure that, we are able to talk with the family, get their support, but specifically from the husband, from the head of household, sitting down and having a chat with him and saying, this is what's going on. Do you support it? If we get you on board, that would be really great. And so that's exactly, I think, what you're hinting at, is that moving forward, we really need to be looking at engaging the family and the husband specifically. Yeah.
Thank you. So we have a question online. I will read it out for you for all to consider. So, do you see any potential for telemedicine or long-distance therapy where cell phones and technology is used to provide mental health services in hard-to-reach areas?
Yeah, I think telemedicine, as well as using cell phones, are great ways right now, solutions. In the Indian population specifically, it's definitely difficult because you're going to have to be very innovative with populations that aren't necessarily literate. So if you're trying to send text messages, you're going to have to be really creative around making sure it's definitely verbal communication. But yeah, I think that's definitely a step forward. We should be combining health and technology.
Thank you very much. Anybody in the room have a question? Yeah, go ahead. Right, so the question in the room has to do with the project that Nicola went and helped out with. So how did that project in India get started, and how then could we possibly replicate that project in other areas of India?
Great, great question, Sheena. So Project Burn started about a year and a half ago, and now I've never actually been told why it specifically started. I know that the reason that it was able to function is because it's linked to Emmanuel Hospital Association. So many of the people that I talked to were talking about the role of civil society in mental health in India and healthcare in general. So because it was linked to an NGO, that's where it was able to get its funding, start its project and move forward. And so I think that we're seeing in a lot of areas, Sangath in Goa, another mental health NGO, is also able to start programs in communities based on not-for-profit organizations.
Thank you. Anybody else have a question for Nicola? Yeah, go ahead. Okay, so the question in the room has to do with why Northern India is it in terms of its research. So why is it unique, perhaps, from Southern India, let's say?
Yeah. So while I don't know I don't know all of the answers to that question, one thing I would think of is, like I talked about Sangath, and some of the research institutes as well as the NGOs are mostly based in Southern India. So they're the ones conducting a lot of research in states like Goa in the south. And so a lot of the studies I'm reading are all coming out of Goa. And the population and culture is hugely different, has similarities, but that's why this research is very important. Yeah.
Thank you. Anybody else have a question in the room? Yeah, go ahead. So the question in the room has to do with language barriers and how you overcame them.
Yeah, that's another good question. I was told to highlight the fact that I spent several months learning Hindi, both in Canada as well as on the ground. And although I tried as hard as I could, I was able to understand a lot, but there was much of what was being said that I could not understand. And so to overcome that, I think I was able to work with a really incredible woman, Pooja Pillai, and she was the one who conducted the focus group discussions. So I could understand parts of what was being discussed, but I couldn't conduct them myself. So it meant that we had to have really solid communication between the two of us, so that I know what I want to do, and I communicate that directly with her, and that we're on the same page at all times. Yeah. Yes, that's a great question. So yeah, what I'm working on right now is creating a page of English and Hindi that would summarize my findings, as well as be able to have the community health workers go back to all of the groups, because they still see them once a week, and to tell them what we found. So I really want this research to help not only the women, but I'm also looking at the NGO themselves, because this gave them a lot of insight into what's working in these groups and what's not working. Yeah, great question.
Thank you. We have a question online. So the question is, was it difficult to get the word about this community-based initiative to women due to the barriers like freedom of movement? So how did they get the word out to everybody?
Yeah, that's difficult for me to answer because I'm not the one forming the groups. When I arrived there, the mental health support groups had already been running for a year. But it's definitely very difficult because we're looking at the population where some of the community health workers are working in a population of thousands, and they only have 1 or 2 mental health support groups. So it's difficult to get the word out, but they're working tirelessly, and community meetings, they call them corner meetings, as well as getting the local panchayat government involved, and policymakers are really making the difference.
Other questions in the room? So the question has to do with the shift away from institutional care and what the focus groups talk about. Was it, and I'll let you finish the rest.
Yeah, so several things to point out there. When we talk about a shift away from institutional-based care, we mean in terms of treating mental health only in mental health hospitals. And so we want to bring it to the community, but that doesn't mean that we want to leave hospitals or medication out of the equation. So in your second part, what they were doing in the group was they were learning, because you have a population that is not going to be able to understand high-level cognitive behavioral therapy, they're learning about mental health basic steps in terms of forgiveness and how to manage and cope with anxiety and stressors and different things that you can control in your life and those that you can't control. And at the same time, I think one of the biggest things was the women being able to say, hey, now we've really bonded, and we know that the other women in the group, they have our back and they really support us. And if we're sick one day, they're going to come to our house and bring us medicine or bring us something to eat. So a lot of it was a lot of bonding in the group. In terms, you were talking about traditional medicine. Yeah, a lot of the women still go see traditional healers. That's definitely happening in the community. But what I saw was a shift away from that, where they're learning about what mental health is and how it can be treated. And in no way are we minimalizing traditional healers, but we're saying, look, you can go there, but also go to the hospital. And a lot of them are saying, yes, we want to take our loved ones to the hospital, and we value that.
Thank you. Any other questions from anyone in the room? Yeah, go ahead. Great. So the question has to do with finances. So these types of programs would fiscally be cheaper than training psychiatrists. So has there been any work in India to look at that?
Yeah, that's a great question. Vikram Patel's work has been, and colleagues have been looking at systematic abuse worldwide, looking at this issue exactly. And they found that, no, we should not focus on the scale-up of psychiatrists because that's not cost-effective in terms of training. What they're looking at, and I can give you the information after, is it's about collaborative stepped care. And what that involves is training local individuals, like community health workers, to be able to work within the communities, provide kind of the treatment and counseling for common mental disorders, but when things need to be referred up, there's someone in the area, and then above that, there's a psychiatrist. So using networks, both at the community, but then being able to refer above that is kind of the next step that we're seeing, and that's, they've proven it to be very cost effective. Yeah.
Thank you. Any other questions from anyone in the room? See, someone's typing online, so that might be a question coming in. So I'll ask another question while we're waiting. So, so here you are, Canadian, a remote hill station in northern India, community setting, talking to women about very sensitive topic. So that could be a challenge for in any setting, but especially in a remote place like that. So how accepting of you were they? And what did you do to kind of make yourself more accepted into their community?
Yeah, so to start out with was how I looked. I wore a salwar kameez every day, the traditional dress, so that I could establish a first sort of connection with the women. And then beyond that, I was trying as hard as I could to learn Hindi and at least speak to all of the women at the groups and try and start some conversation, even if it was minimal. Beyond that, I think that what was important was getting to know the women. So I would spend at least 1 or 2 sessions not doing any research, but hanging out with their group. And so this gave them an opportunity to like stare at me lots and, you know, ask lots of questions. Do I have a husband? You know, how long have I been married or not married? Or and so then once they got used to me, I felt that they were very accepting. And then when I came back the second or the third time, and the community health worker said, hey, she'd really like to ask some questions, they were very receptive, yeah. And they also said that it was exciting for them to see someone come from across the world to focus on something that, you know, a lot of their community doesn't care about. So in another way, they were very appreciative to see this kind of work being done.
Thank you. So we have a question online. I'm going to be a second while I read it out to everybody. So obtaining more mental health training and services for smaller communities in rural areas may be very challenging due to the bureaucratic system of government. How do the NGOs you've mentioned plan to make these changes in the long term? And is this actually feasible on a large scale?
That's a question that's very pertinent right now because the NGO, like I said, it's doing all these mental health programs at the community level, but they've also been working with the policymakers and lobbying at higher levels. So some of the heads of the program have been talking to the Director General of Health at the state level, at Uttarakhand level, to ask questions like, For example, there are no medications in the state hospitals, but the policy says that there should be medications there. Why is there no medications? Where are they going? And so through steps like this, they've actually been able to see a change in terms of, like I said, in September, the National Mental Health Plan was approved in a limited form, but in all districts across Uttarakhand, and they're starting to see medications in some of the state hospitals. So I think that civil society and NGOs have a strong role that they can play across India for mental health.
Great. Thank you very much. Anybody else have a question in the room? So the question in the room has to do with stigma of mental illness and whether or not a program like this could help alleviate some of those issues for people who are diagnosed and have long-term issues, or do you think that's still a hurdle that they would have to overcome?
Yeah, so I'm going to preface this by saying that my study was only looking at common mental disorders, not severe mental disorders, but when I was in the community, when I was looking at kind of one-to-one house visits, it seems very difficult because there is a lot of stigma around it. People don't want to talk about it, and they don't want to, if you're going to talk about it with them, to community members, they may spread that to other community members. But that's why this kind of project is so important, because we're looking at women being able to talk about it, as well as like meetings within the community to say, hey, this is important. And then from there, we can make first steps to say, okay, this is happening. We're not going to place any sort of stigma around it. How can we help this person who's schizophrenic get some sort of help at the hospital? And that's where Project Burns has been really effective at accompanying community members into the hospital and helping them get access to care.
Okay, thank you. Any other questions, either online or in the room? So with that then, without any other questions, I'm going to draw things to a close. I want to thank Nicola very much for coming and telling us about her trip and the work that she's been doing. I'm going to draw your attention to the screen now and just a couple of links that I have there. So the first link, if you're interested in the Queen Elizabeth Scholarship Program, that first link then gives you the information that you need to know about applying. The second link there, if you're interested in our webinars, so every single one of our Queen Elizabeth Scholars are doing webinars. And the list is available at that link there. And then the third link is to our blog page. So all of our scholars are also writing blog posts about their experiences. So these are a little bit more personal, less scientific or researchy based, so more personal reflections on their trips. So all of those blogs will be available at that link there. I encourage you to check them all out and check our schedule for future webinars. And thank you everybody for coming, and thank you very much, Nicola.